Three disorders that are umbrellaed under chronic obstructive pulmonary disease. By obstructive, it can be from inflammation, it can be from mucus production, it can be from spasm, edema, and what else? Whatever the next one. Everybody listening? Okay. Let's start with lymphedema. How many of you taken care of someone who has lymphedema? Okay. By anatomy alone, you see that healthy alveoli, it's a problem with the alveoli. That's why we call it the grapes of wrath. First of all, healthy are elastic. The morphology is round, they're elastic. You have the optimum exchange of oxygen and CO2. But with emphysemic patients, that O2 stays in the alveoli. They can't get out as readily, the O2. Therefore, that O2 is there, and the person with emphysema, if O2 is there, you give them more O2, they lose that drive to breathe. So what perpetrates them to breathe, they need to have that CO2 at a level where that it potentiates that oxygen demand. If you give them more than 2 liters of O2, you wipe out that drive to breathe. That's why if you have someone who's not in a code setting, but comes in with COPD, you start out with 2 liters. And it's nasal cannula. Now, you'll see some people who have COPD. They have chronic issues. What are some habits they may have even though they have this condition?
Smoking.
Smoking, which causes constriction. The oxygenated blood may get there, but with COPD, you get that oxygenated blood. It's impeded because of the constriction from cigarette smoke, and plus the O2 is there in those alveoli. So what would you hear if you listen to their lungs? Wheezing. That air is trying to get out. Now, that air is trying to get out, that O2, it's stored there, but the person can't get it out, so you can have the regular circulation, get reoxygenated and what have you, because you need your lungs to pick up that oxygen supply so that it can then recirculate through the heart and out to the periphery. So you'll see these people where that they're breathing faster, but it's not optimum for oxygenation. You'll hear the wheezing. It can be on inspiration, it can be on expiration, it can be all the above. That's irritating to the tissue. So what is going to happen in relation to this irritation to the tissue? Mucus, inflammatory response will occur. Mucus can occur in those lungs. So you can have wheezing going on plus crackles. Okay? Over time, it'll go to here. I usually say, here are the grapes, the healthy grapes. Down here, they became raisins. So therefore, you're not getting the gas exchange, CO2 and oxygen. So what would you see in this person? All the things, and you're going to tell me, all the things related to hypoxia. What would you see?
Confusion.
Let's start up here.
Confusion.
Some confusion, some anxiety, irritability. What might they be trying to do?
Sit up for support.
Yeah, they're orthotic. And also what they may have going on is they become barrel chest because of trying to breathe out that breathe out readily, and they become barrel chest. You'll hear a term where the AP diameter is enlarged for your barrels and compared to the periphery barrel chest. What might you see them trying to do if they've been taught relative to their lips?
Pursed lips.
Pursed-lip breathing. What might you notice about their skin color? You may have said it already.
Ashen.
Remember, cyanosis is a lake sign. What might you see in the neck area? They may
retraction.
have distended. What's that? I can't hear you. They may have retractions if they're so compromised. Because with retractions of the intercostal, but these muscles are tense in the neck. Question?
What is retraction? What does that mean?
Like caves in when they breathe.
Yes. So when they cave in, you will see them, the airways will flare. They will look like help me breathe. You'll see all of this accessory muscle use. I've seen respiratory failure so bad that he was literally what we call air hungry. He was like a fish out of water. So he was gasping for air, and it looked like his back and his chest were meeting. That's how contracted he was. And he just couldn't get air. And that's
That's not the time to be thinking, how can I help you relax? Call a coach. Okay, hit the back button. Okay. Now, you see what's going on with the patient. We talked about the skin. It may be action. The temperature of the skin might be, if there's no infective process going on, might be cool. What is their activity level?
Non-existent.
Minimal to none on some people. How can you facilitate them? Someone already said it. Facilitate for them to get more air. Said it. Sit them up. If you see them walking around and they're short of breath, it's not the time to say, the doctor wants you walking. You sit them down, have them have rest periods. If they don't understand personal breathing, you teach them.
How do you teach them? What's a good way to teach them how to do personal breathing?
Just have them demonstrations.
They don't know how to do it. You got to tell them.
Take a breathe in deep and breathe out slow.
Or you can tell them to smell the roses. So everybody smell the roses and blow out the candles.
I like that.
When a person has COPD, what is their, like, I know it varies for each person, but average, like, oxygenation, saturation, I mean, what's
I'm
the
glad you
difference?
asked that. I've had patients come in and your optimum level of oxygen you want is 90 and above. Some of these people come in the 80s. They've compensated over time. They can live with that. So you'll have physicians to say, well, let's get them up slowly, unless they're in close situation. Get them up slowly. Their norm is 88. I've had guys walking around in the hallway and they're at 84. But you have that O2 tank and you have a chair right there.
Yeah, my mother-in-law frequently dips down into the 70s, and but yeah, or anything that
She smokes too. Of course she
and all the above, and she refuses oxygen. So we just gotta watch her, and if she starts too bad, that's when we make her go. Because she refuses to have like an ambulance call to go to the doctor. So I was just kind of wondering where,
And another thing to remember, if that's that person's norm, they've compensated, You try giving them more, another problem may arise. So you're giving them too much. Okay, so we know they're not getting enough oxygen. What major organs are affected and how? What's the heart going to do by compensation?
Pump harder.
They're going to be tachycardic. Okay. Yes, let's go with the heart and then work that. Okay, tachycardic. What condition of the heart might occur as far as morphology?
Enlarged.
Well,
It becomes enlarged, but it's not.
make them.
It's enlarged, but it can't. It loses its contractility force, so you don't get enough cardiac output to perfuse the body, and they don't have enough O2 in the first place. Okay. Working down, what might you see renal rot? How would you know there's some complication relative to renal? What is your indication?
Increased output.
Decreased urine output? What would you see in the labs relative to the urine?
The bun and the creatinine will raise.
Raising of the
B1.
blood urine and creatinine. Let's back to the lungs. Okay, I forgot that. What lab, not lab, but arterial blood gases will be done. Okay. Now, there are some people, when you do their arterial blood gases, you're not getting that, the gas exchanges. What metabolic condition might they be in?
Acidosis.
They may be in this respiratory condition. It's a respiratory condition. It's going to be respiratory. It could be metabolic if everything's
Acidosis.
Acidosis.
because they're retaining what?
CO2.
You can have mixed also, so you know that. But typically it's respiratory acidosis because you're not getting that CO2 out. Okay. And the O2 squirt is not having their supply. Okay. What might you notice? You already said the Vivero chest. You'll give them O2 at how many liters?
No more than 2.
Unless they're in a closed situation. Okay. What medications do we need to give to this person to help them?
Albuterol.
Bronchodilators. Okay. They dilate the bronchus, main bronchstem, your smaller your bronchiole. Okay, what is the expected goal when you give them a bronchodilator? Open up the airway. You would expect, if they were diminished lung sounds, you would expect to hear more air exchange. Also, what would you expect the pulse ox to go to? Go up, okay? And then when you do a next arterial blood gas, you would expect the levels to start coming back to homeostasis, okay? Now, what is the side effect of giving someone a bronchodilator? Tachycardia. What else? If it's given orally, what might it be? Think about it. Anything we said, there's NORS you'll find with all GI upset. So GI upset, you also will have the tachycardia. A lot of times when people come into the ER or directed into a unit, the tachycardia from being hypoxic will bring them in, but also once they take that medication to help them, they're breathing better, but it throws them into a dysrhythmia. And so and I'll digress a little bit to tell you, one of our co-instructors here, her father-in-law had, what did you say, was it just a regular bronchodilator inhaler?
It was a different kind of inhaler. You can dial it and check how many times it's been used.
And he had used in a 10-hour time frame in conjunction with respiratory treatments. He had used it 240 times.
Oh.
And wondering why his heart was this, and he was still smoking and doing what he wanted to do. But, you know, he's still with it. But anyway, the thing is, he's going to do what he wants to do. So, yes.
Like my son is severe asthmatic, so he has to take preventative meds and carry his inhalers on him. And he's a track runner, so a lot of times like they'll give him the inhaler, but it says on it, you know, you only use it so many times within this amount of. But he don't listen. If he's breathing bad, all he wants to do is feel better, so he'll just start pumping it, you know. And I try to
So
tell
he
him,
can perform better.
yeah. So it's like I think sometimes, you know, I don't know. So by that.
So these people, what else does he take while we're on?
Singular.
Singular. Okay, so what is singular? What else?
Singular and albuterol. The singular actually helps him a lot for some reason. Take that daily.
Relative to an inhaler, if someone's taking an inhaler and you don't know anything about that med, there's a method where you can put it in water to determine if it's full or if it's half full. Are you familiar with that or saw it above? Basically, you take an inhaler, you put it in water. If it floats to the top, what do you think?
It's empty.
Huh?
It's full.
Mm-mm.
It's empty.
If it's full,
It's gonna go down more.
it's gonna sink that weight. If it's midway, it may be somewhere in the middle of the water. If it's empty, if you see it laying up there like a goldfish right at the top, it's not the time to be saying, "Oh, we'll use this while you go out." Okay. What does it mean to you that? Okay, let me just say it this way. A person may have two types of inhalers. Why might they have two types of inhalers?
One would be a steroid.
Bronchodilator, and the other one might be a steroid, or one that's steroid and bronchodilator together. Which one would you think? You have a steroid and you have a regular bronchodilator. Which one would you use first?
The dilator.
Bronchodilator, you want that air down there. Then you'll use the steroids. What's the problem with using steroids as a side effect when you're letting that steroid inhaler go into the mouth? What happens to the mouth? Thrush can occur. It's opportunistic infestation that can occur.
So that's why they have you rinse out after.
Yes. So, a question might be, your patient is being discharged, you're doing discharge teaching, and they're on a steroid inhaler and plus a bronchodilator. What demonstrated by the patient would alert you to the fact that they understood your teaching? They're going to say they'll do oral care frequently. They will use their bronchodilator first. Then they'll use the steroid. They will follow the directions of which the physician has given them for use, multiple uses of the inhalers. It could be choose all that apply. It could be what would alert you to the fact the patient needed more teaching, or what would alert you that they understood you. Three different ways.
Is that only the steroid inhalers that'll cause the thrush, or is it albuterol?
Anytime you're using a mouthpiece, you have the density of bacteria from your mouth.
And is bronchodilator that?
You can take bronchodilators orally, but you can take it through an inhaler. But if it's an inhaler, you need to watch that. Okay. If you see your patient kind of jittery anxious after taking their inhalers? What would be your response to that? Huh? That might be the thing, like they got it took 240 and 10-hour time frame, okay? So besides having tachycardia, there may be some jittery.
Not normal.
It's normal, but if you take 240,
Well,
okay. Now, what other ancillary service will be working with this person?
Respiratory.
And they may be giving different treatments on this person every 6 hours, or 4 hours, every 6 hours, and PRN. But when you have someone have their own medications at bedside, and this was what the case was, you want the person to take only what the hospital provides, unless the hospital does not have that inhaler in their formulary. Your care with this person is going to be geared at what? I said it earlier. Okay, if they have where they're going to go to, let me just give you some. This person is going for some cardiac testing during the day sometime. They're going to be having their breakfast. They're going to be getting a bath. They're going to be visiting with relatives. You want to space those activities. If it's a relative that comes in and reeks of smoke, unless the patient smokes too. If that person reeks of smoke, you need to do a teachable moment to that family member too. It might even be the doctor that comes in with cologne or clothing also that you're glad when they make rounds and they'll mention and they leave because your patient gets worse because of the irritant. That happens. So with these individuals, you want to minimize the effort of the heart and the lungs. So you space the care. Okay. Anything else you want to say, Chris? Another one is chronic bronchitis. This is a condition where it's inflamed and there may be a spasm that's going on, thus making it constriction. It's inflamed, thus there's edema, and there may be some spasm going on, and this green in here might be exudate, drainage. Layman's term, pus. Purely drainage is what you need to say.
No.
Okay? So, this person's not going to get that air that get really aerated in the lungs because of that constriction and the edema. So, you'll have someone who's constantly wanting to cough. If you listened at the bronchial areas, what would you hear on them? You might have some wheezing and cracking. See a trend that occurs if the inflammation is there or any drainage, you may have the crackle. Some people, you may have a bronchi, real hoarse. What are you going to do to help them liquefy those secretions?
Increase fluids.
If they feel like it takes every effort for me to drink, where they're candidate for IVs, hydration. You want to encourage these people to sit upright, semi-Fowlers or higher if need be. If they have supplemental O2, nasal cannula. What's the greatest amount of liters of oxygen you can give through nasal cannula?
6.
6. If they need higher than that, they're probably very compromised and they're not a candidate for med surge per se. There's more going on with this person. Okay, what will be given to decrease the inflammation?
Steroid.
Steroid, oral form. It might be IV route initially, and and then you taper it down, they're going home, it will be, oral route. What are the side effects of steroids? Irritability again, and might be the peripheral, the weight gain, what else?
Is loss of sleep part of
Oh, yes, because
Okay.
of the irritability that's going on.
blood sugar?
Blood glucoses may go up, but they'll let a patient tell you, and they're diabetic along with having bronchitis that, oh, it's because of my illness. You see chips and El Taco, all the above over there. You know, that's not the case. So, these people may be initially on IV route for their steroid and also tapered down. Steroids are always tapered down. They're never abruptly stopped. Question might be asked, you have a patient that is on steroids, and they say to you, this just irritates my stomach so bad. I'm just going to take this dose and I'm not going to take any more. Your response is you need to take take your medications, they will be tapered down, and then you will be off of these meds as a result of your recovery phase. And then you need to tell them, maybe we could give you what to help you. What could you give them? Something, what could you give them food-wise to help them? You want to give them milk?
Oh, no, not her.
Okay.
Well, milk does.
You might have someone take a few crackers or something to help settle the stomach. Okay. Day 2, these individuals also may have respiratory treatments. What might their cough sound like?
Wet,
Huh?
like a wet cough.
It'll be crackling. It'll be, the bronchs are up here, okay? So it's real audible. I can't do it right now, but it's real audible. You know, you listen to them, you almost can't hear the lung sound. I mean, the heart sound. Sometimes you can't hear the heart sounds as readily with someone who's been to see them because of the adventitious sounds you're hearing. Okay. Here again, this person, you're going to space their care. Itis, what will they be on in relation to maybe not only the anti-inflammatory steroids, what might they be on? Antibiotics. So here again, this person would take all the dosages of the antibiotics. What's going to be the determinant to know that this person is getting better? Well, it's a patient that's saying, I'm breathing better, the coarse lung sounds will diminish. X-ray wise, what will you see?
If you're chronic, does it really ever get?
Never goes away, but there are things that would exacerbate it, make it worse. What are some things that would make it worse? And think about it, respiratory in general, what are some things indigenous to our area here that would make their respiratory status?
Dust.
Dust, things in the dust, perfume,
bleach.
bleach, that's bleach, someone said that the other day, who uses all that bleach? Okay, seasonal allergies.
Well, I read it, this may sound stupid. How do you determine bronchitis versus emphysema? Because it's very, very similar.
It's similar, but the thing about it, with emphysema, they may have those other symptoms over time with chronicity, the barrelness. You don't necessarily have the barrel chest per se with bronchitis. There's going to be some other symptoms. An X-ray is going to show you if they're getting better. They may even do CT scans with this person if they're determining if something else is going on. And you know, if they're doing a CT scan and it's with contrast, you're going to do what?
Assess for
Assess
allergies.
for allergies.
Question.
I think I want to go back to who had that question about the difference between bronchitis and
Kim.
bronchitis you can go in and out of that. So there's a potential for you to get a little better. But damage is done every time that you have a flare up of it. With emphysema, the damage is done. There is no repair. That person is only going to decline and get worse.
Yeah, that's just it.
Right. There's no surfactant in there. Those alveoli are collapsed. There's no, you're just not going to get that.
So like when the babies are born premature and they aren't born with a surfactant, can they produce it still?
No, they're given
They're given a shot.
surfactant until they reach their
The adults
gestational age. Adults.
And I'm gonna tell you now, with respiratory, you do similar things for similar symptoms. Asthma. Of course, you have the normal bronchioles and an asthmatic. See the edema that's setting in. There may be some drainage, and you have the spasms. What will they sound like?
That's what you're doing.
Wheezing. Predominantly wheezing. If there's some inflammatory, some type of coexistence, there might be some crackles. What would exacerbate their situation? Same thing that would have allergies.
Smoke.
Okay.
And my house, I can't use bleach. My son just has immediately. I have to use like lemon-based products.
Okay.
So like bleach is just, I don't know.
Okay, so irritants such as dust, what's in the dust,
test.
cat hair, dog hair, perfumes,
Air freshener.
those strong air fresheners, yeah. So,
Any Glade is bad.
it's aerated type thing. So, to show you how this manifests, I did a home visit on a little lady. She was widowed. Husband had died, I think it was a year prior, and she didn't have his companionship. So, what was her companionship?
The dog.
The dog or cat.
Cat and dog, which she almost tripped over because she had glaucoma and cataract in one eye. And so I'm going in there doing a home visit, and my assessment: what are the problems here? She's a
Pets.
fall risk all the way around. She already has some eye problems, and here's this cat that's right by her. That's what cats like you; they're right by you. And she's about to trip. And she's had arthritic problems trying to walk with the walker, and the cat's right here. And so I go into her house to do a home eval. I see all these barriers. Plus, she's there. She has her O2 on. Plus, her
Well, she's not
grandson
smoking.
came to visit her. Didn't take care of her, but came to visit with her. And he was smoking outside of the house, but he didn't wait till he got outside the house to smoke. Sometimes he would light up in the room, and her O2's going. He has a cigarette in his hand. Bye, Grandma. Here's the O2 right here. Here's his cigarette right here. These are teachable moments. I did a total eval of that house, plus did an assessment on her, and it was total neglect. She had children. She had people who could help her. And plus she was depressed because her husband had died. And so she ended up where she was in an assisted care place. That was a referral for her. Because she was not safe in her home. And she wasn't safe with that grandson around either. So you need to look at the environment of your patients. You need to ask them, tell me your typical day. You can alert the case manager who's assigned to that person as to what if it's a safe environment to go into. Now, let's get back to asthma. We already said things that would perpetrate an attack. There's a condition called status asthmaticus that you will get into block 4, but what do you think might be going on with status asthmatic? You know they have asthma. Chronic
Status.
hypertension. They're not responding as readily to medication management. What are they a candidate for? Your monitored use. Sometimes they're so bad, they end up in ICU. I'm going to digress to Professor Dunn and have her describe to you two differences. What she's seen in the elderly, what she's seen in a child.
Kids are really fragile. And for us, it's cardiopulmonary that'll kill us. For them, it's respiratory. They can't compensate. So when you do teaching with parents or caregivers, it's very important for them to understand what those child's triggers are. We had a guy who he was 10, but he was the biggest 10 I ever seen in my life. He would come in all the time because his asthma would act up. But he was one of those asthmatics that would close up like this and would cold right in front of you. So when he would come in and he was hunched over, and if I was a triage nurse, I was like, I'm not messing around. Give me a wheelchair and get him straight to the back. I mean, he made 5 a week, so if he collapsed, there was really nothing I could do for him. They need to learn what their what's that thing? Peak flow. They need to know the peak flow has different zones. So you have a good zone, which is green. You have the yellow zone, which is, you're kind of getting in trouble. And then you have the red zone, you're in trouble. So you need to teach them to do the peak flow. This could be an adult or a child. We, living in Wisconsin, just like 2 weeks ago, it was 60 degrees. Guess what it is now? 21 cold. Okay. So imagine the swing in weather. And then guess who would all come in? They had on shorts, even though it's February, really, people? And then 2 weeks later, we got on our coats and boots and, running to our cars, trying not to be frozen in mid-step. So that weather would, cause an asthma flare. Severe cold. The spring, what happens in spring?
Pollen.
All right, so if you already have allergies and you have pollen and all those things, what some people don't understand, and Professor Denson started there, is just because you smoke outside, where does that smoke reside?
Stays on your clothes.
Okay, your clothes, your hair, your hands. So just because you smoke outside, you're still bringing those irritants in with you. Apparently, Brandy loves bleach. And
I can't use it anymore.
oh, I'm sorry. I do too. So I have to be, cognizant of that if I know somebody has asthma. I did home visits too, and if they had cats or dogs, I would sit there miserable because I'm allergic to those things. And if I start to wheeze, then what do you think that means? I'm starting to get in trouble. My inflammatory response is not working anymore, so I need to leave. People love their animals. They, some of them consider them, their children. But if it's killing you, and you still like animals, well, maybe we need to find some kind of animal that doesn't what?
Shed.
That doesn't shed, right? Doesn't kill you. So if you like, I don't know if you eat cats unless it's that little ugly cat from, what's his name? Austin Powers. No, yeah, whatever. I don't know what you can do about that. I know there's several different dogs that you can get that don't shed or have low dander. Cleaning is very important. Where do we live? And it's always what?
Dusty.
So it's kind of like a no-win situation. I don't care how often I dust. Like 5 minutes later, I turn around. It's a layer of dust. So pretty much enough. Paint. So doing simple projects around the home. If you have asthma, what would you like to tell them to wear if they decide to paint or do yard work? Just little things that they can do to prevent a flare-up. Your albuterol is your rescue inhaler. So teens, school-age kids, if you can play a video game, you can teach them how to use their inhaler. And they need to understand that. Brandy brought up a good point. Her son plays sports. They need to have at least 3 inhalers at any event. One kid played basketball with my son when he was in high school. He never had his inhaler. Never. And he had an asthma attack one day. And they came running to me. I was like, I can't do nothing. He doesn't have an inhaler. What do you want me to do? He's still breathing. I mean, it was kind of harsh, but they looked at me. I'm like, this is why you need your inhaler. His mom was livid because she had told him a million times you need to carry that inhaler. But if they get so far and they're so constricted, is that albuterol going to help? No. So all those things are going to teaching. The elderly, if they've lived with it a long time, they're going to do what they're going to do. So like your mother-in-law, our co-worker's father-in-law. I mean, they lived with it this long, it hasn't killed them yet, and apparently some of their thought process, whether we agree with it or not, is what is their time is their time. And it doesn't matter what they do to change it. So you can only reinforce, not change, and move on from there.
Another trigger that we found out from working with y'all students is when you have to do a presentation, someone may go into okay, due to the stress of being a diva, she went into an attack during her skit. Another student was her rescuer.
Like for real.
She
For
was
real?
holding it, and it was mouth to mouth. I'm not lying. I am not lying. When I heard about it, my glasses just went off. And I don't even believe she brought her inhaler that day.
It was too far from her.
Too far.
And she was fragile asthmatic anyway.
Very. So, from all of these disorders, what are the commonalities relative to, with COPD, relative to emphysema, bronchitis, and asthma? First of all, there's some type of obstruction, be it a inflammatory type of edema setting in, a spasm, or mucus. Relative to emphysema, the air is getting there to the alveoli, but over time, the elasticity is lost, so you don't have that optimum gas exchange. They're retaining that O2, they're trying to blow off some CO2. You want to give them 2 liters of O2. If you're in a cold, you want to do big guns. It's not the time. You want to do what's necessary to get them back. With emphysema, there are things you can do as a nurse. Sit them upright. Minimize their O2 demand. You've done these care plans. You want to encourage them, if they have inhalers, keep them filled. Know if one is getting empty or is empty. Have spares. If they are having a bronchodilator and a steroid inhaler, which one will they give first and why? Bronchodilator. You want to open up those bronchus. Then you want that steroid to get into that tissue. Okay. What is a side effect, expected side effect when someone takes a bronchodilator?
Tachycardia.
What is your goal when you get that bronchodilator? Increase oxygen for body supply. Okay. If you saw a person sitting, what position of sitting would alert you to the fact that they might have emphysema? Leaning over something. They're going to be orthotic, but they're going to try to lean over something to assist them in their breathing.
Why? I don't understand how that helps them.
Because
To have, like, where they're pressing it?
okay, you'll likely see them on the bedside table like this, and they're trying to, along with being up, they'll try to breathe, thinking that the body's the airs and the gases in their alveoli, they're trying to help get it out. They're using the pursed-lip breathing. And over time, they become barrel chest. And so they figure if they're up like this, if they're in bed, that barrel, think about a barrel like this. If you sit up, it's better. Because you have more gravity helping to get that oxygen and plus blow off that CO2. Yes.
What exactly is bronchospasm?
It's just like this.
So how do you tell if somebody, if they're asthmatic or bronchitis? Because I mean, all of
They're going to be coughing. And once they cough, they'll go back right into the cough. They'll say, I feel like I'm getting a little air, because they're just spasming. And you'll see the pulse rising. You can't actually see those bronchos,
Well, no,
but you can tell because even though they're coughing and everything, it's not helping. It's not helping at all. So that's why they say with asthma, it can be the spasm that's going on along with the edema.
Think of the bronchospasms kind of like when you were talking about those, with cardiac, we were talking about the, we talk about the
Fibs.
spasms, your coronary arteries can have a spasm, vasospasm. Those are pretty dangerous because if that person is spasming, that means that that lung tissue is very, very irritated. What can happen? It's already constricted. What can happen during one of those spasms? The airway will totally close up. So someone who is having like an anaphylactic reaction or an allergic reaction to something, they can go into bronchial spasm. And the main thing is we need to get that airway open.
What's an independent function besides sitting them up that's going to help them if there's mucus? You know by listening to the lungs that any of these conditions, that mucus that's collected, what are some independent functions you can do? Encouraging the cough. What types of fluids? Okay, if they say to you, oh, I love milk, that is not a choice. Because milk produces what?
Mucus.
Question back there.
What about coffee?
Coffee? Okay, even though the caffeine can be constricting and it can make some people irritable, at least you're getting something in them. That's what I've heard some physicians say. At least you're getting some liquids into them. It's a diuretic though, but at least you're getting something into them. I tell you, when you do your home visits, if you become a public health nurse, if you have a patient that at least is drinking something, that's better than them. You tell them you can't have no coffee anymore.
Isn't caffeine also a bronchodilator? I thought.
It was good for us.
Yeah.
I don't know. Coffee every other morning. It seems like
Yeah,
I
there's
get
some new
positive
research.
about coffee. I'm like, yes, right.
But the main thing you want to get good. Okay. Preferably ones that are not just water. But if they're coughing and everything, they may not be able to drink as readily. And if people are compromised where they're not drinking as much fluids, they're going to become dehydrated. So they're going to be hospitalized eventually because you need that hydration along with them coughing. So they may need a little assist. What two main groups did I talk about? Bronchodilators and steroids. And your ancillary health is your respiratory. Okay, anything else you want to add?
What other medication can you give to help with those secretions?
Wait, for which one are you talking about?
All of them can produce secretions. Every single last one of those. Your emphysema, your chronic bronchitis, your asthma. And if we need to get those secretions out, if for some reason they can't cough it out, what other medication can you ask the physician for or expect?
Mucinex,
Mucinex. What is Mucinex?
Mucolytics.
breaks it up.
So it's kind of like that. And what is glyphenisin?
Thins it. I don't know what
It's
that
It's a
is.
robitussin. So what does it help it do?
It's a mucus,
It's an expectorant.
yeah.
So the mucinex is gonna help loosen it up and get it where they can cough it up. And the robitussin or glyphenisin, you can do it in a tablet or robitussin. That's what glyphenisin is. That's gonna help them cough it out. If they can't handle their secretion, how are we gonna get those secretions out?
Suction.
Suction.
So the two documents are decongestion and expectorants. All right. I kind of gave you some segue into how questions may be asked. I'm going to tell you, with respiratory, these three respiratory elements, it's similar care. A lot of your respiratory disorders is similar care. You want to get those secretions thinned out. You want to get supplemental O2. When you get to these disorders, you want to do the bronchodilators. You want to do the steroids. You need also to do the decongestion and the expectorants. Okay. Next Tuesday, after Professor Zoom finishes her portion of her lecture, she'll start today to finish next Tuesday. We'll do a concept limit. That will be only 2 sections, respiratory and immunity. We want you guys to feel better and understand better so that you bring your scores up. It's not all about scores, but understanding. And with both of us plugging along and helping you, this is, and you have similar care, you can kind of cluster your thinking. This is the way I do things. And for the most part, students do better on the second exam. We've trended, and that's what we want you to do. We want to assist you in doing that.